Good afternoon, everybody. My name's Anthony Brown. I'm the CEO of Health Consumers New South Wales, and I'd like to welcome you all to this very special presentation on our visiting guide for family presence in a COVID normal world. I just ask people, if you're not speaking, if you wouldn't mind being on mute, please. To keep the mute button on. Please keep your video on. That's great. We'd love to see you. It's nice when we're talking to know that we're not just talking to an empty room. And because we've got so many people involved, I'd ask that if people could please open the chat room and please ask any questions and make any comments via chat. We are recording this briefing this afternoon, and we're going to make it available to people who weren't able to join us. So Serena, if you could just go on to the next slide, please. Before we start, I would like to acknowledge the traditional owners of the various lands that we're all meeting on today. I'm coming to you from Kensington in Sydney, which is on Gadigal land, and I pay my respects to the traditional owners of this land and to the traditional owners of all the lands from across New South Wales and across the country who are on today, and pay my respect as well and welcome any Aboriginal or Torres Strait Islander people who might be joining us today. I mentioned that we're meeting on the land, many different lands from across the country. 90 people who've registered for today, which is fantastic. And people not just from New South Wales, but also in other states and territories. And really pleased to see we've also had someone register from Scotland. So welcome, person from Scotland. It's great that you're able to join us. I think it's about 3 AM in Scotland. So thank you for getting up and joining us. And if you're watching us via the delay, we quite understand why you've done that. So I'd also just like to say one of the great things I think about the acknowledging country is it reminds us of the importance of community and of leaders and the people who've gone before. And I'd also like to pay respects and acknowledge the leaders of the consumer health movement and all the various people and consumer leaders who have done and continue to do such great work. This presentation today, this paper, this guide, is the result of so much work with consumer leaders, and I want to acknowledge and thank you all. If we could just pop onto the next slide. Just reiterating what I said before about mute and keeping the video on. Please use the chat function. We won't be able to actually talk to you, unfortunately. But if you could please feel free to introduce yourself to everybody else in the chat. If you have any questions or comments as they come up as the presentation progresses, please put them in the chat and we'll refer to them. We are monitoring them. We will do our best to answer all questions, but I'm sure, as you can appreciate, with 90-something people, we may not get to everybody, and if we don't get to your specific question, we'll do our very best to come back to you at the end of the meeting. And as we're talking, if people are aware of other resources or other things that would be useful for us to know about, by all means, please let us know about those resources and add relevant websites to the chat as well, because that's also a really useful and rich way we can get information and ideas from people as we're going along. As I said, the briefing will be recorded and we'll play that back for people who can't attend. This is normally the time, if we were meeting in the same room, where I'd tell you where the emergency exits are and where the toilets are, but I'm assuming you know all of that from where you're coming today, so thank you. And yeah, next slide, please. For people who aren't familiar with Health Consumers New South Wales, We're the peak health consumer organisation in New South Wales. We work with patients and families, carers and health services, and we work to ensure that consumer engagement, consumer voice and consumer experience is all taken into account in health service planning, and that consumers are directly engaged in decision makings that affect us. Nothing about us without us, as you all know. We're an independent charity and we're a membership-based organisation. So anyone who's not a member, if you like what you hear today, if you like the work of the visiting guide, I really encourage you to come online, look at our website. So I don't need to tell everybody how much the world has changed in the last few months, how much COVID-19 has affected not just health services, but all of us in our everyday life. And we've been very aware and very concerned about not just the impact of COVID-19, which of course it's the main thing, but we've also been concerned with a lot of things that we've seen happen in the health system. One of the main things that has happened is that the actual involvement of health consumers and health consumer representatives, family representatives, carer representatives, in the past few months, we've been very concerned about the decline in consumer engagement across the system. And I think we're all very concerned that a lot of infrastructure that for years we've been involved in building up around consumer engagement suddenly felt like it went by the wayside when we were really needed and when we could really make an input into what's happening in helping health services plan their response to COVID-19. Health Consumers New South Wales has been a number of ways that we've tried to bring consumers into the conversations. We continue to advocate for consumer and community engagement across the system. And we've also formed a number of key task forces with consumer leaders and consumer organisations to continue to advise us on what involvement about issues that are important to consumers and making sure that that continues to be heard. We've established a consumer representative hub, which is an online engagement platform for consumer representatives across New South Wales. And we've used that hub as part of the discussions today to inform what we've done around developing this visiting guide. And if people have a chance to visit our website and to look at amplify.hcnsw.org.au, you'll see some of the work that we've done, and particularly work that we've done around looking to engage people using online engagement tools. We know that that's not perfect, but it's been one way that we've been able to maintain that conduct, that connection. We've also been very involved with New South Wales Health as a member of their NGO Community of Practice, which is one of the ways that they've involved the sort of centralised planning around the health system's response to consumer engagement. And that's allowed us to be a conduit between health consumers and New South Wales Health around those issues that have been raised. Could I just go on to the next slide, please? So I hope people have had a chance to have a look at the visiting guide, which we released a couple of weeks ago. And on page 30 and 31 of that guide, we've got details of the process that we've gone through in order to develop it. And this diagram is from those pages, and I won't go through that in detail, but I wanted to let people know that from the start, issues around visiting and family presence in hospitals in particular, has been one of the key issues that's been raised with us. And when we formed the Consumer Leaders Taskforce back in April, that was one of the main things that people were talking to us about, and visiting was seen as one of the key priority areas that we needed to address. So what we did was we looked at the existing literature that was out there, and we did a quick literature review about what other people and other organisations were saying. But we also went out and spoke to the Consumer Task Force, but also to patients, family, health consumers and consumer representatives about what they were seeing and what their concerns were. And we used the Health Consumer Hub as a way, as our way to do that. And once we did that, we went back to the Consumer Task Force with the key issues that we believed we'd identified, and we spoke with them around clarifying if people thought we were on the right track, adjusting the report and the responses according to the feedback from the task force. And we also searched Care Opinion Australia as a way to identify other stories that people were sharing around their issues with visiting. We did a search for visiting and from Care Opinion and saw what people were sharing around their concerns around visiting. So, and through this process, the report was developed, refined and finalised. And as I said, there's more details of that in the report that I encourage you to read, but I just wanted you to know that we really went to a lot of effort to make sure that the starting point was the issues that consumers were telling us was important. And then as we developed it, we kept going back to make sure that we were on the right track. So the guide was completed 2 weeks ago, and we've been working hard to distribute it quite widely. So of course, the first people we sent it out to were the people who were involved and to our members in New South Wales. So we want to make sure the consumer representatives have this and are able to use it as a resource in their own work with local services. We sent it out to our members, and we sent it out to members of the task force and to the consumer hubs. We've also shared it with other consumer organisations, of course with our members and members of the Consumer Organisations Task Force, nationally with Consumer Health Forum and the other state and territory consumer peaks. We've sent it out quite widely through New South Wales Health, starting with the Secretary. We've sent Elizabeth a copy and all the Deputy Secretaries in at the Ministry, the Chief Executive of all the local health districts, the pillars and specialty networks, as well as to the Chief Experience Officer, and to the consumer and community participation managers who sit in all of those organisations and who manage and support consumer engagement. And I think we have some of those people online today, so welcome to all of you, and we're glad that you're involved. As I said, it's only been 2 weeks since the guide's been out there, so this is by no means everybody will be sending it to, and we'd welcome further suggestions in the chat around who else it could go to. And I'd also encourage all of you to please share it with your own networks, with consumer representatives that you know, and to consumer groups and health services and other services that might find it of use. So who does this guide apply to? We'll hear a bit more from Laila as we in this next section about that. But when we put this together, our starting point was people who use health services. And so health services, I suppose, are the primary audience. That being said, we believe that it is relevant for other residential services and we think that aged care, disability services and other residential services might find this of use, and we encourage them to look at the principles. The first principle in this guide is that people involve local consumers in developing their local visiting policy. And so that's the big caveat that I put on that in order to make sure that when other services start to use this, please use local consumers and the consumers of your service as a way to stress test what's relevant for them and for families. We use the term COVID normal, and I just wanted to touch on that and say that that's been quite deliberate, because we believe it's quite clear now that we're in a COVID normal world, that for the medium term at least, we all have to learn how we live with COVID and learn how we live and adapt with the results of that. So we've moved beyond that initial emergency response, and as we go through future, hopefully not future waves of COVID, but we do know that the situation is very fluid and can change quite rapidly, that is part of the normal world that we're now living in, as you said, at least for the medium term. So it's time for consumers and consumer representatives for us to be back in the discussion, and we're offering this as a way to go forward with visiting policy. During the course of the briefing this afternoon, if people have personal experiences around visiting that you'd like to share, well, of course, people are welcome to share that in the chat, but we'd also really encourage people to go to careopinion.org.au and to let people, and to use that as a way to share your experience, because that will also have a wider audience and an audience with the health service or the other service that involves. So I'd just like now, that was really my introduction, and I'd like to hand over to Laila and welcome Laila Hallam. Laila's the chair of the Consumer Leaders Taskforce, amongst many other things, and one of the co-authors of this report. So after that introduction, I'll hand over to Laila. So thank you, Laila.
Thank you, Anthony. What a pleasure it is to have so many people around this virtual table. It's so great to have so many people interested in what is a critically important area for our patients, and a challenging one in our current environment, especially one where COVID apparently just wants to continue to stalk us. As mentioned, thank you, Anthony, this work was initiated and developed by the COVID Consumer Leaders Taskforce in conjunction with Health Consumers New South Wales. So it's been a big collaborative effort. And it's touched a whole range of feedback mechanisms, experience mechanisms, so that we could pull together and try and get as broad a picture as we can of the situation. Just a note also about these slides is that they've been designed to be used by any of our consumer reps and staff within their own organisations. So when you have a look at these, they will actually be available for you if you choose to use them, and they should be able to guide you through the issues. So they're sort of designed so you don't necessarily have to have read the report, although I would strongly recommend that you do. The slide deck will be available on site, and Serena will be able to give us more information about where you can access them if you want to. Next one, please, Serena. As Anthony mentioned, any comments during the presentation, feel free, throw them onto the Zoom chat box, and we'll come back to them when we have the panel discussion. And if you have any personal experiences you want to share, we encourage you to use careopinion.org.au. Thank you, Serena. I'm going to actually open with two stories. They're two contrasting stories, but it tends to magnify the situation to give us a bit of a broadness about maybe how patient experience, how people are feeling about family experiences. So the first story is my genuine thanks in making my parent and our entire family feel welcome. During this time, we've all had to deal with the COVID-19 crisis, and the staff and management have gone above and beyond to ensure that we can still visit our loved ones during this time. They're always welcoming and ensure that all checks are completed prior to entering the facility. I thank our nurse who identified an issue and provided a solution to ensure my parent was happy and comfortable. It really made us feel that everyone matters to the staff. And the next story, after 5 weeks in palliative care, in a palliative care hospice, the COVID lockdown occurred and the 2 daughters were advised only one could visit for the duration of her admission. No amount of negotiation provided a solution. The other sister was not even allowed to stand in the courtyard out of her mum's room to wave. The difficult decision was made to transfer her to a private hospital so that the sisters could both continue to visit her. She died 18 days later. We need to come up with better ways to manage the safety for staff and patients while managing the expectations and family and keeping them safe. Thank you, Serena. And then this one seemed to sum up the mood of much of the feedback and what most of the consumer reps were witnessing. And that's we're seeing COVID-centred care rather than patient-centred care. So I'm going to begin by disentangling and contextualising some of the considerations that arose so we can so that we could actually get to the heart of the issues. So as Anthony mentioned, we are talking primarily about hospitals and other health facilities. We're talking about public and private, about inpatients and outpatients, but most importantly, we're talking about all patients, whether COVID and non-COVID related. This guide can also apply to disability and aged care residential facilities. So even though we didn't focus on the area, we didn't come out focusing on this area, we found that in fact the principles apply equally validly. Thank you, Serena. We've taken a risk mitigation approach to family presence in our COVID normal world. Now, I'm going to say these slowly because the risk that we're talking about is balancing the risk of family presence on COVID infection spread with the risks associated with restricting or not allowing family presence with patients. So one is about bringing family in and the risk we share with spreading infection. And the other one is about the more silent and often less seen risk of what happens when families are excluded from their patients whilst they're in a healthcare facility. The approach we've also taken is that this is not prescriptive. The guide was not intended to be prescriptive. Instead, we focused on outcomes. What is it we wanted to achieve and sort out the barriers and enablers to get us there. So what we're trying to achieve is meaningful family presence. It draws on the expertise in patient and family perspective and does not assume infection control expertise. It respects the differences in health environments and services and the communities they serve. In a nutshell, different facilities and different communities will have different needs. It values and encourages innovations that occurs when we explore the different approaches. The guide also recognised that together we're stronger. The key stakeholders working together is far stronger than anyone working alone. It embraces and reaffirms the fact that COVID is a threat to all the stakeholders, patients, families, staff, community, execs, everybody. All are responsible for keeping each other safe, and no one stakeholder will succeed without the support of all the stakeholders together. And for that reason, we've taken the risk mitigation approach rather than a demand list, because we understand that containing the virus is as important as having our families there. So one of the first issues that arose was that when we talk about visitors, who exactly are we talking about when we talk about patient visitation? And it turns out really there are two different types of visitors. There are the people who patients choose to have by their side at critical points in their treatment or care. And there are the others who are no less important, but in the scheme of it can have a different role. And they're the well-wishers. They're the people who come to wish you well, to provide some entertainment. That's not a bad thing. Provide our flowers and our chocolates. But at the end of the day, they're not the people who are critical. They're not the people who we've actually focused on in this group. The people we focused on are the patients who we choose to have by their side at critical points in their treatment or care. The focus of the guide, so when we talk about the patients choose to have by their side at critical points, well, what exactly are we saying? So we're saying that family and friends, carers, care partners, partners in care, they're all used interchangeably because the idea is that it's whomever the patient chooses to have by their side. It's often more than a single person. Its family or care partners are not limited to blood relatives. So throughout this guide, even when we use the term family, we are not necessarily talking about blood relatives. We are talking about the people who we choose to have by our sides. They may include spiritual leaders, and the guide is equally supportive of patients who choose not to involve family or friends, as it is to support them if they change their mind at any point. So it's not telling people what they should or shouldn't be doing. With regards to critical points in care, so who defines that? And patients and families do. Now, we deeply understand it and recognise these needs at birth and when dying. Patients can experience mixed emotions whilst in the midst of health events, fear, anxiety, anguish, as well as relief and joy, and sometimes all at once. If we agree to the principle of having somebody there when we need them most, then it will be in place for those very intense times like birth and death. So in addition to birth and death, it can be critically important at other times, like when people are receiving a new diagnosis. It might be a life-limiting or a life-altering diagnosis, when new treatment decisions need to be made or when treatments stop working. And when relying on family to help recall symptoms to give clinicians a full and complete picture. And when preparing for discharge, and especially into the care of a family member. There are lots of reasons to have people by our side, and sometimes we need them when maybe the staff don't actually, and sometimes we don't even realise when we do. At this point, we're talking about patient needs and patient perspectives. So it's worth reminding both staff and consumer representatives of the role that consumer reps play in making that happen. Consumer reps represent patient and family perspectives. They are the core stakeholders in healthcare design and improvement who partner with clinicians and executives. And they identify, interpret, and build patient perspectives into the system, guiding and aligning policies, structures, processes, and team culture. That then enables staff to anticipate and respond to patient needs easily and routinely at the bedside. That's why they're important. With regards to stakeholders, you'll hear the report often talks about stakeholders, and there are 4 critical stakeholders. There's the health staff and other workers, and this guide, the common ground to all of them, you'll find there's more that unite us than actually separates us. Health staff and other workers need to have confidence that they can come to work and go home without unduly risking themselves, their families, or their patients. Patients and their families need confidence that they can seek care and will receive it uncompromised and in ways that will facilitate their healing. The community need confidence that the provision of these health services is not leaking infection more broadly, and policymakers need confidence that the policies that they develop are supported and followed by all. Essentially, we are all singing from the same song sheet. So as we start to explore this area, some critical issues arose. Patient and family isolation and disconnection from each other, and the family from clinical teams. the spread of COVID-19 and the
Laila, I
uncertainty.
don't know if you can hear me, but you're frozen. Good.
Yeah.
Okay.
And the uncertainty and unfamiliarity with a changing environment. The problem is in balancing the risks. A family presence. Serena, can you change the slide? Thank you. So what we're trying to do is balance the risk. We're trying to find a happy medium that is going to work for an extended period of time while we have to deal with COVID-19. So it's family presence on COVID-19 infection control, balanced with the risk associated with restricting or not allowing family presence with patients in the short term and the long term. So why do we care so much about family presence? For very good reasons. There is plenty now of documented clinical evidence to suggest that involving family and friends in care improves patient outcomes, and it does so in a number of ways. It does so by improving communication between clinicians and patients. It does so by improving patient adherence to treatment and ongoing condition management. It also minimises preventable risks and reduces adverse events. And I'll just give you one very quick example of that you'll probably all relate to. Having a family member by the bedside when a patient is receiving medication often can be an early warning signal when the family says, no, that medicine is not one that my patient takes. So they have some real bedside purpose, and sometimes just having someone checking is important. They support the obvious smoother transition for patients between healthcare settings and to home. They improve clinical and personal outcomes, and they influence patients' willingness to seek and receive care. And that will be a particularly important one for us right now, because as we're receiving so much information about COVID, there has become a fear of coming into our hospitals. So we need our patients to be supported by their families to know that it's safe. So what are the goals? What are we reaching for? We want to recognise and accept family presence as the norm while minimising the risk of infection, introduction and spread. We want to explore new and innovative ideas and solutions with patients and families. So we want people to look at this differently. We want to plan as a system and apply locally and review on facts as the situation changes. And we want to be able to restore and revitalise stakeholder confidence so that together we've got this. Now, with regards to recognising and accepting family presence, can I just ask everyone just to check that you're on mute? Thank you, everyone. The goal for recognising and accepting family presence actually has two pieces to it. One is about making sure that families and patients stay connected to each other, so they're there when they each need each other. Families with patients and treating teams is the other component, and that is having family. Now remember, these are the people who are often the care partners to patients. Having them there in real time when the patient's with the treating team. And of course, this is all prefaced by the fact that patients also choose to have their family members there. But having family members available when the treating teams are there is very important. Okay, so the 9 principles that guide this family presence, what you'll see, so you can see all the 9 principles there, and below in blue, in the blue box below, is each of the principles. The first one, as Anthony mentioned, you can change it now, Serena. The first one that Anthony mentioned is probably the most important, and that is what we all know is stakeholder partnership. Nothing about us without us. That applies to all of us. That applies to clinical teams. That applies to infection control expertise, and it involves patient and family expertise. So bring the stakeholders together. And it includes also our community leaders as part of our patient and family representatives. bringing us together around the table is where we begin from the outset. Stakeholder partnership also means being able to accept responsibility together. It's about being in partnership. It's about being collaborative and being and having reciprocity. Reciprocity means that we are each doing it for each other. It's about sharing the commitment, the goals, and the decisions and the outcomes. So from system design to bedside implementation, from embedding patient and family-driven feedback systems to capture, identify, and address needs, and to having representatives to canvass widely and deeply to inform decisions. It's a commitment that we're all working together, and we're working broadly and within our expertise to be able to get to the best possible place. The second principle is about agreeing on our goals and letting the expertise guide. So we need the infection control experts to tell us how to make the environment safe. But we also need our patient and family expertise to identify and navigate what those patient needs are and to support the responses at the bedside. And then we want to align the system, the service, and the bedside responses around these goals. Principle 3 is about preparing infection control and setting up the environment so it begins from a COVID-ready level of virus protection. That means that we can't even begin to have this conversation until we've done the background, until we've done all the background that we need to do to make sure that our environment is as safe as we possibly can be before we introduce more to the equation. So we want to make sure that our infection control is as robust and as rigid as it can be to prepare us for safe visiting. We also want to make sure that the measures begin from entry to exit, and to plan infection control practices that are proportionate to the COVID level of risk faced, so that they can be escalated and de-escalated easily and as required. And to do that, we have to be planning and ready for it to change those as needed. Principle 4 is about mindset. It's about focusing on needs and a commitment to focus on needs and to consider ourselves problem solvers as we sit around these tables, allowing needs to guide the ideas and responses for desired outcomes. To commit to seek and focus on needs, understand them, truly understand them, rather than to continually try and solve things that we don't genuinely understand. From stakeholders, patient, staff, and community feedback, existing patient experience mechanisms, they're the things that are going to tell us, that are going to inform our needs conversation. Recognise that other stakeholder groups will bring insights and unearth needs and bring new and different ideas. We all bring something different. And commit to thinking differently, commit to accepting that there is going to be some difference, and open our minds to work out how we can accommodate. Principle 5 is about identifying the risks of negative consequences and explore the options to mitigate. This is essentially saying that we do understand that there will be decisions made and agreed to that will have negative consequences for one of the stakeholders, for maybe all of the stakeholders. But mostly if we've done our job well, we'll know most of them and they will be foreseeable. The idea here is to make sure that we prepare for them so that they can be preempted. So seek to understand the problems, don't assume to know, and explore the ideas and the options as we go. Principle 6 is about filling the need gap. Now here we tended to focus on when physical family presence is restricted. But principle 6 is actually about any need gap that there is an opportunity cost where we've decided the cost is too high. But in this particular case, we've said, okay, well, where the risk of family presence is too high, we know that we still need family presence. So the idea is, okay, then what? And it's about adapting to maintain the connections, accept that the connection is required. And now this is about finding ways to accommodate them, and making sure that it's done in real time, and particularly for patients and families, but also during during treatment when the treating teams are coming through and there's rounding. So making sure that families still have access in real time with what's going on. Using resources, technologies that are available, easy to access and use, and identify the barriers within existing protocols and review them. Don't just accept them. So it might also mean that what we have traditionally decided that we can't do because of a previous protocol, maybe it's time to review the protocols. This Principle 6, though, also applies, though, to any need that we've identified that we actually can't, that we might be limited in being able to deliver to. Principle 7 is about getting ahead. It's about planning ahead, prepare as a system and apply locally. Why? To minimise the adverse risk to patients, families, staff and services. And to minimise the burden on frontline staff. If the more we consider the adverse impacts and the needs that remain unaddressed, the more we can actually deal with them, find ways to accommodate them, and it takes the pressure off the frontline staff to have to continually try and find ways to deal with it. It also frees them up to be empowered to resolve these, because there will be some thought that has gone into them beforehand that they will have access to. So how do we do that? Apply the principles consistently from system policy through to bedside delivery. So that really is about consistency all the way through, from the beginning to the end, from policy through to bedside, consistently and transparently, so that our staff who may not be actively engaged in the process are still fully informed. And well, it's not actually even just our staff, it's for our staff and our patients, so that they can see how these things, the purpose behind them, and they can see there's a transparency that goes with how we've done this, and always compassionately, whether it's staff or patients and families, always compassionately. Principle 8 is about communicating honestly, consistently, clearly and widely. I think that doesn't require a whole lot of thought. However, it's probably one of the biggest areas that we struggle with. So this is also about saying we need to bring expertise together. It means bringing the patients and families so they are core to the messages that are going out there, and they guide how those communications actually get out there, and include the community leaders who are able to disperse, who are able to communicate and disperse and lead those discussions. And ideally, many of these people will actually have been involved from the outset. So in fact, this should not be difficult for them. Explain the rationale and the actions required. So give your audience the benefit of explaining why we're doing things, and be very clear on what is it that we need for individuals to do. Find multiple ways and across multiple channels and platforms to deliver the messages. There's no one right way for everybody, and there's no one right way every time for anybody. So use multiple channels. Communicate in advance so that expectations are set, so we avoid surprises. And principle 9 is just to continually reassess environment and refine iteratively. Base the decisions on current factual information, available evidence and grounded experience. Adapt and refine accordingly, and continually reassess. Now, hopefully one of the things that you'll find with these principles is that in fact they build on each other. If we have planned, if we are sourcing our information, we've got the right people around the table, we are planning, we are understanding our needs and we're planning for them, we're communicating them, then reassessing the environment is something that we will be able to close that loop with. We'll have the tools in place to be able to close those loops. So in conclusion, and where to from here, Health Consumers New South Wales and the COVID-19 Consumer Leaders Taskforce strongly recommends the principles be incorporated into reviewing and refining family presence responses to prepare for the significant and ongoing uncertainty COVID-19 presents. It wants us, we all want to have our combined expertise brought together so that we can achieve the best possible result, both for our patients, our staff, our families, in the safest way possible. So I'm going to leave you with our final story, which is in fact our aspiration. My child recently had an emergency dash to the hospital in the late afternoon. By the time my child was admitted, it was too late for my second child and I to travel back to our rather remote rural property. The kindness and compassion of accommodating our needs was outstanding, and we're deeply grateful. The two nursing managers assisted us in negotiating the novel challenges surrounding our stay with such grace that they transformed what could have been a very stressful time into a calm, manageable experience where I feel everybody's needs were met. They were prepared to spend precious time meeting with us, understanding our predicament and addressing them. God bless them. Compassionate and strong leadership, capable of adhering to complex COVID protocol while not losing sight of the very real needs of the human beings under their care. My spouse and I salute them both. The hospital is in magnificent hands. Thank you, everyone.
Hi, thank you so much, Laila. Serena Joyner here. I'm Consumer Engagement Manager at Health Consumers New South Wales, and I am going to facilitate a bit of a panel, and I would invite you, if you have questions for Laila or Anthony or any of our panel members, please put it in the group chat. I know I probably won't get to all of them, but I will do my very best. I'm just going to make sure I have unmuted. Kelly Foran and Jan Mumford and Luke Escombe. So I've invited you to unmute yourselves. I hope that's worked. And I'm bringing these three members of the Consumer Leaders Taskforce in to join Laila and Anthony on the panel. And I'd like to start with a question to each of you, Luke, Jan, Kelly and Laila. Why is enabling family presence a priority for you?
Who's going to be brave to go first?
It looks like you, Jan.
Thank you. Look, it's a priority for me because in my work with people, it's the continuous engagement with the health system. So people who have chronic and ongoing conditions, or their children have rare genetic conditions, that means they have continuous involvement with the health system. They're often stressed, and also too, as a result of those diagnoses, they have a form of PTSD, if you like, and that is the best way to describe it. So in additional stresses, dealing with the system, the hospital system and COVID, they need to be a part of the journey with their child, or for themselves if they've had ongoing treatment. So it is really important that they have the means to be able to communicate with people and to be supported during that time. That's...
Thank you. And Kelly?
I think probably for me, where I live, which is very rural, having that other person there, or being able to have two people to take in the information, and truly, you know, the problem shared's a problem halved, and you know, it's an awfully big decision for one parent or one person to make decisions and understanding new treatments. And you know, without that person beside you, as Laila indicated in some of those slides, there isn't, sometimes there's not much uptake. Sometimes as the patient, you certainly don't want to go on with the treatment. You need that support. You need that holistic. I understand everyone's pretty skilled, and thank goodness for that. I'm very grateful for what our clinicians do, but you know, I need to know that my family or someone's there to support me as well holistically.
Can I just Can I very quickly tell you a quick story about my experience working on the cardiology unit? So I spent quite a bit of time on the wards actually. I like chatting. Anyway, I spent a lot of time going from patient to patient. Of course, that was pre-COVID. But one of the things that I found was, I met a lot of pretty amazing people who were lying there, often after a heart attack or some sort of heart incident. And I'd find a lot of particularly men, middle-aged men who were jokey and jovial and trivial and chatty and all of those things. However, when I sat down and actually spoke to them after a while, I got so many of these men who would cry. And that's because they had just gone through such a huge event in their life, a huge trauma. And for a lot of them, they just weren't talking about it. And to have their family present and by their side to be able to help them work through those, I think, particularly those traumatic moments, I think is critically important.
Mm. Absolutely.
Yeah, well, thank you for that story about making men cry, Laila. I feel like as a middle-aged man, I might follow that and say, my own experience, the last 2 times I've been in hospital, one was for an ileostomy, which is a life-changing surgery. And the kind of mindset that you enter into in those first couple of weeks, especially the first few days after surgery, is so crucial for your entire mindset about this enormous change in the way your body works going forward. So having my wife there meant everything. And I think it's really important to remember that when we've been through a big operation, we're not just lying there passively recovering. We are running a marathon there. There is so much mental work, mental and physical work going on in healing and learning to cope with what we've been through. And we need support teams there. It's absolutely vital. My decision to have an ileostomy was because I found out I was going to become a father. So having my wife by my bedside with our 4-month-old baby bump there was so important. And a few months later, she was in hospital for 6 weeks with preeclampsia, and I was able to reciprocate. I was able to be there by her bedside the whole time. And we've just celebrated 20 years of marriage. And when I think back about what's really held our relationship together through all of these tough times, when I think about love, I think about the hours that we've spent by each other's hospital bedside. I just think it's something that it's not just about the week or the few days that you're there in hospital. It's something that resonates throughout the years. It's of such great importance to who we are as human beings. I think it's absolutely foundational to person-centered care to remember that as human beings, we're not just individuals, we're part of relationships and partnerships and communities. And that is something that can't just be cast aside. It has to become something that we think about moving into this new COVID normal world.
Thank you, Luke. That's such a good message, and it strikes to the heart of why this is so important and why our consumer leaders and consumer reps have been so passionate about it. I have some questions coming in from the chat, and one that I'll start with is, how does this guide include children visiting family members? I gather visiting family members who are in hospital.
Do you want me to pick that up, or?
Yeah, Laila, can you respond to that?
I think with regards to, so the guide is intended to be a set of principles that can be applied across any environment. So when we're talking about, we haven't written specifically for any particular audience. Now, parents with children are more likely to be able, at the moment, more likely to be able to look, I actually don't know. I think this is where we sit down, and this is where the organisations come together with its patient base. And in that particular case, it is to do with our parents of our children and coming together and say, okay, well, what is it that we need to make this work? It's a discussion that we need to open up with our facilities if, in fact, you're not already, if, in fact, visitation is already a problem.
Yeah. I think that it starts to lead into another question around how can this support the particular needs of people where English is a second language, or where they don't speak English. So, Laila, how would you respond to that in terms of how can this guide address those needs?
Well, that's where community leaders becoming increasingly very important. And that's why we haven't been prescriptive at all, because within our facilities, they will have different communities. And the job really is to identify who those communities are that are being touched upon and reach out to them and start this discussion. And it's not just, it's people who don't speak English, it's people who have, who are dealing with disabilities. It's all of those areas. So even though we're talking about most of our patients are vulnerable, some patients are more vulnerable than others. And recognizing those becomes critically important. And that's where consumer reps start to unearth the different, can start to unearth some of those things that sometimes we just assume.
And I guess different services and different wards can have a different cohort of patients and families that they are actually, supporting or serving. So that's where considering these principles on a service by service, ward by ward basis is going to be really important with those consumer partners. We've been asked if the presentation slides will be available online. We will make those available online, along with the recording of this briefing. And so everybody who registered today will receive an email to let them know how to access those. They will be available on our Amplify site and probably our website as well. We may have them in two places, but we will definitely have them published. And we had a question. How would you respond to this? And this might be one for Anthony. Given that aged care is a federal responsibility, how can we put this document forward for all Australian facilities? I'll just unmute you.
Oh, great, thanks, Serena, and thanks for the question. So, as I said, our starting point was for this document is health services in New South Wales, and we'll certainly can make this available, and we'll direct this to people at a national level. There's no reason why we can't send this to people in the Commonwealth Health and Aged Care Department. I think we can also share this with the various older people's organisations and older people's consumer organisations. I know that there's some people online from some of those organisations, so I asked them also to please use your networks there. So we'll certainly do our best to make sure that that goes out to those facilities, and ask you as well to use your networks in aged care, whether that's locally, regionally, at a state level or nationally, to help get it out.
Mm-hmm. Thanks, Anthony. This is I guess this is a really important question. It gets to the crux of part of the problem, and it's come from Yumi Lee. Our medical system has been stripped to the bone. Staff are so stressed having to make the most with what they have, that this great document will be guidance that people wish they can use. When you don't have enough staff to set aside the time to negotiate, discuss and facilitate this during COVID times, how can we translate this document into something which can be practically used? So anyone on the panel, you're welcome to speak to this.
Okay, I'll kick that one off. Firstly, I think one of the reasons that we have gone so broad with this document is that it's a discussion starter. It's what we take from the top of our health system throughout to go and be able to open these conversations with our staff, with our executive, and start asking how and why these decisions are being made and whether we can do things differently. This is the chance that we have to bring us together around a document, around a set of principles, and find ways to work through them.
And
sorry.
Kelly?
Go ahead, Kelly.
I was just going to add a little bit to that as well. As you know, as I've been reading with the chat, it seems to be we are reverting back to just the no, you know, the blanket, no, can't do it, no, can't have more than one person. And, you know, the crux of the matter is, you know, consumers of health and the patients and our supporters are so important. And, you know, we seem to have forgotten that. And yes, we are trying to prevent COVID spreading, and we're trying to make sure we're doing all those things. But I think we have to really look at this and look at this document and open this conversation, because the cost in the big picture is going to really start to hurt and bite others. And, you know, I understand hospital systems have been stripped and things like that. But I think a lot of what we want to do is very simple, and it's not going to cost. It's, you know, if we have something put in that, you know, everyone supports and it's a better default than a no, then, you know, we can all work together. A very quick story I've got is, you know, I had a family whose 10-year-old was diagnosed with type 1 diabetes. They were travelling 3 hours to the hospital to be with their son, and one parent at a time. You know, that's all that could happen. It could be in that room, and it created problems down the track because the parents weren't getting the same message. They were having a conversation in the car park, and you know, they've now gone home, and there's a real family issue there now because, you know, that information sharing, that support wasn't there for that child. So we need to look at the big picture. And, you know, I just think this is just an amazing way that, as Laila said, we're all getting together to do it.
And can I say thanks, Kelly? I think you've really hit the nail on the head that, you know, some of these things that we can look at don't need more funding. That being said, we all need to continue to advocate that our health systems and our health services get the funding that they do need. And the other thing that I would say is, like, we are so much stronger together. There are people on this call who are consumer representatives who are sitting on key facility, hospital, local health district committees. There are people on this call who are chairs and members of consumer advisory committees. And I ask those people to please take this and take these principles and, you know, put these on your on the agenda for your next meeting. I think one of the things around consumer engagement is that sometimes we can be our own worst enemy as consumer advocates because we wait for permission. And I think we've battled our way onto committees, we've battled our way to build up these structures, and now's the time to use them and to say, you know, us to start setting some of the agenda here. So please, I ask all the consumer leaders on this call, and there's a lot of you, and I think you have power that you don't realise you have. And please take this guide, and if you believe it's useful, and if you believe it's pointing in the right direction, ask for it to be discussed at your next meeting. Talk to the managers that you know, and let's start to use that influence.
Anthony, if I could just add one more thing to that. I strongly suggest that when we're having these conversations, take it back to safety and quality. Having family presence actually makes for safer and more effective care. So if we actually want to dent our system from the perspective of being able to save resources and save time, the best way we can do it is to get it right at the first place. So having our families there by their side is one of those ways. We just have to find ways to do it safely.
Thanks so much, Laila and Anthony, and also Jan and Kelly and Luke for contributing on the panel. I'm just going to close out that part of, before I hand over to Anthony to close the meeting, to say the things that really stood out as the consumer leaders and consumer reps were working on this whole topic was that it comes back again to patient-centred care and partnering with consumers. And they're at the heart of our health system and our accreditation system and quality and safety. So it's not sort of asking for the ridiculous. It really is. These are the fundamentals of our great health system. And it's, you know, in challenging times, but those things are still just as important now as they ever were. Anthony, I'll just hand over to you to close.
Okay, thank you so much, Serena. So thank you everybody for your participation today. It really means a lot to us. Thanks for your engagement and the questions and discussions in the chat. There's a lot of really valuable information there, and we thank you all for sharing that. I'd also like to thank Luke, Kelly and Jan for your time and joining us on the panel today. Luke, Kelly and Jan are amongst the people who commented on the document, and I thank you for that. And there's other people from the Consumer Leaders Taskforce who did that who are online, so I want to thank you all. Thank you all as well. Special thanks to Laila and Serena, not just for your work today on this briefing, but for leading us through this process. Laila and Serena are also co-authors on the report, and I thank you for that. As I said before, please take the report and use it. Please let us know where you've used it, how you've used it, and any suggestions, because we really hope that we really want this to be the start of a conversation and not the end of it. So we will be continuing to promote the guide and the principles there. And if consumer representatives aren't yet part of the Consumer Rep Hub, I really urge you to join that, and that's a way to keep involved in these conversations. And we'll send those details out to everybody by email as well. Before I close, I would like to let people know that we are going to be repeating this process with another key priority that consumers identified, and that's around the issue of telehealth. So shortly we'll be asking consumers, families and consumer representatives to join us in an online discussion about telehealth to kick off that conversation. And again, we'll send everybody out those details by email. Thanks everyone for your participation. We have gone 10 minutes over time, which I apologise for, but it was such a rich conversation, we really didn't want to cut it short. Thank you. We'll keep you all informed by email, and we really appreciate your time this afternoon. So we'll say goodbye now. Thank you.